Hey everybody, I'm Maggie and we're on another episode of SRH Access Facebook Live and we're here with Dr. Lane Wimberly. Welcome.
Good afternoon.
We're excited to have you. Today we're in our movement science lab, so a little bit later we're going to have a demonstration of how that works. But today we're talking all about cerebral palsy. We're really excited to learn more about this patient population. Dr. Wimberly is a specialist with this, so let's get started. Okay. What is CP?
CP is a blanket term. It's a description basically of a neurologic injury that was sustained when someone was very young. So usually before the age of 2 or 3, something's happened such that the brain has been ultimately affected. And then that can lead to any number of differences as children grow. Some that can walk pretty well and some that can't walk, and it can affect cognition and other parts of development as well.
So is this something that a child is born with, possibly?
Yes and no. The definition of cerebral palsy is that this has happened when someone is young. It can be up to age 2 or 3, depending on how you look at the definition. And some children can have an event when they're still in the womb, which would lead to this, but most of them are after delivery due to one reason or another.
Okay. What about, how is it diagnosed? When they come to Scottish Rite, what is it that specialists are looking for?
Sure. So the diagnosis of cerebral palsy is oftentimes made before you get here, and sometimes it can be made when someone is still in the neonatal intensive care unit. We typically see children that have differences in the way that they walk and sometimes in the way that they talk or use their hands. And those can be some of the first signs that we'll see around here. And then if we have some suspicion of the diagnosis, then oftentimes they see our neurologist to have further workup that includes oftentimes an MRI of the brain, because that's the way that you definitively show there was a difference in the brain that accounts for what we're seeing in our clinic.
Right. So obviously here at Scottish Rite, Facebook Live, we got to go with it. So Scottish Rite, we handle pediatric orthopedic conditions.
Right.
So what are the most common conditions that are associated with CP?
Sure. So as I mentioned, children with CP can have a huge spectrum of clinical differences. Some can walk pretty normally with maybe a little bit of a toe walking difference, and then some can be really significantly involved where they're in a wheelchair and they can't sit themselves up and they can't hold their heads up. And so the spectrum is huge. And when they come in, we base our care on sort of what they're doing and what our expectations are and what we can do to either keep them as good as they are or potentially make them better, or to make sure that their caregivers are as helped as they can be.
So CP with every condition has 2 extremes. So we have ambulatory and non-ambulatory for CP patients. So what is the difference between them?
So by definition, that's those that can walk and those cannot walk. And even those that walk can be separated into those that walk pretty well independently and those that really require a walker and some other assistive devices to get around. And the treatment, it really differs depending on their ability. And so if you have a child who can walk and has been doing very well for a few years and is suddenly having some difficulty, they're having contractures, they're starting to lose what they have had in the past, then sometimes surgeries can help you keep what you currently have. For children that don't walk, we're typically trying to do things that help with caregiver care or help people sit upright better or to make sure that they're more comfortable.
Okay. You were talking earlier about neurology being a department that really helps out with this patient population. So what other areas within the hospital help out with this? Because it's a multi-center.
No, clearly cerebral palsy, as an orthopedic surgeon, I'm a very small cog in the wheel that all these kids need. They need a strong pediatrician, and lots of people come with someone from the outside because a lot of them have feeding issues and respiratory issues or seizure issues that they take care of. In the institution here, we have a pediatric developmental specialist that helps us with these kids, either perioperatively, so around their surgeries, or long-term care, depending on what their needs are. We also have neurologists here that specialize in movement disorders, so we don't spend a lot of time necessarily on their seizures, if that's the reason they're here, but we try and take care of them more of a movement-based approach, and so we'll help treat their tone, and that can be medications or injections or even implants that sometimes deliver medicine to their spine to make them
that's
walk better.
awesome. I know one of the really cool places, which we are currently at, is our movement science lab.
It's one of the cool places.
Yeah, very cool. Kind of like a video game a little bit. So what is the involvement of movement science for these kids?
So movement science is, for us, a special department within the hospital that lots of academic centers have, but ours is really quite well designed. We have kids that come in that can walk, and we light them up basically and watch them walk several times, and we can get a lot of information on how they move, perhaps what's limiting their ability to walk better, what maybe we can change that might improve their ability. And so it helps us as a preoperative study a lot. And then we can also look at someone afterwards and see if we have really made the change that we expected to do, and sort of objectively identify our outcomes. So it's a very nice tool to use before and after.
Cool. Well, I think we're at that point where we're going to actually get a live view of how this works. We recruited somebody out in our clinics. Her name is Mary Helen, and she's all marked up. And so I think we're ready to go, right?
Okay, good luck, Mary Helen.
Come on out here. So you can go ahead and stand in the box in the middle.
And this is our Director of Movement Science. This is Kirsten, and she's going to show us what's going on.
Great. So the first thing that we do is you can see Mary Helen has all these markers on her body, and we've basically put those on very specific bony landmarks. We did that in advance. So what we're going to have her do now is just stand real still, and our computer is going to take a static calibration. So it's going to be a way for our computer to understand exactly where all the parts and all the markers are placed. So that's our first step. And then once we collect that, come on down here. We're going to have you do some walking. So go ahead and turn around and put your toes on that tape. And when I tell you to go, just walk straight down to the other tape, turn around, and wait there for me to come back. So go ahead. Great job. So the whole goal here is that she walks as she does typically in the outside, you know, when she's in the community walking around. So just come on back, just try and be natural. Move your arms a little bit. You look kind of stiff. There you go. Excellent job. So once we get all that data into the computer, our real output is a series of graphs. So you can see here we have a bunch of graphs, and each line represents one leg. So we have blue lines representing the left, red lines representing the right, and then we have a bar, a gray bar, and those gray bars represent, you know, age-matched, typically developing, you know, kids who don't have cerebral palsy or any other conditions. We always compare our patients to those individuals to see where their differences are. And Dr. Wimberly can probably tell you how we use this information in clinical decision-making.
So as she mentioned, we like to use this both before surgeries and after surgeries, or even just to collect data on kids as they grow, because they may walk one way at age 4 and then change as they get to 7 or 8, and so we can compare the differences that we're seeing clinically. And this gives us very objective data. So we see true angle measurements of how the hip, the knee, the foot moves. We see how well her foot placement is, if it's facing the proper direction, and what may be changing or what may be influencing a gait pattern that's not so good. And so you can see in a typical developing kid, we can see their foot facing forward, their hips and knees and everything moving very fluidly. In a child perhaps with some neurologic differences, you would pick up on different, maybe the knee doesn't move as well, or the hip doesn't move as well, or the foot doesn't place down the way we expect it to. And so we watch the video of the child. We look at the graphs that we generate that gives us very objective numbers, and then we look at our physical exam. So we see if the knee does move the way it's supposed to. And we put all of that together, and then in a collaborative effort with clinicians and movement science staff, we're able to come up oftentimes with some reasonable expectations for surgery. Or perhaps not surgery. We might find that despite what we see clinically, that there's not really a surgery that will change someone's gait pattern. But we put all this together and try and use it as scientifically as possible.
Awesome. That's some really good information. I think we don't have any live questions, which I don't think we do, but we're excited to be able to have Dr. Wimberly here to show up our Movement Science Lab. So tune in next week. We'll have another episode of SRH Access. Thank you.
Thank you.